then the clinical presentation of pheochromocytoma. How can you diagnose and how can you manage these patients? So what are catecholamine producing tumors? What are catecholamines? Do you guys know about catecholamines? Must know them. Adrenaline and noradrenaline, or in other words, epinephrine and norepinephrine, the flight and fight hormone. So these are produced from the adrenal gland, mainly from the adrenal gland and from the sympathetic and parasympathetic chains, which are present in our the sympathetic chain along the spinal canal, and the parasympathetic at specific areas. So how are these? There are three main types of the catecholamine producing tumors: neuroblastoma, ganglioneuromas, and pheochromocytomas. So what happens is, how are they formed? There is neural crest. From neural crest we get the, in embryological stage there is a neural crest, you all remember. Then from there we get the sympathoadrenal progenitor cells, which are also called neuroblasts. So neuroblasts are converted into, if they undergo the mutations, they can become neuroblastomas, usually seen in babies in the younger age group. Then the neuroblasts, they differentiate into two types of cells: the chromophene cells and the sympathetic ganglion cells. The chromophene cells, they are present either inside the adrenal gland or outside the adrenal gland, and they are called pheochromocytoma, their tumors. While the sympathetic ganglion cells, when they become tumorous, they are called ganglioneuroma. So pheochromocytoma 1, then we have paraganglioma originating in extraadrenal sympathetic chain or chromophene tissue. So when this pheochromocytoma, when it is present outside the adrenal gland along the sympathetic chain or chromophene tissue, it is called paraganglioma. It's chromophene because chromophene gives a yellowish, these masses are of yellow color. On examining, when they are removed from the body, they have yellowish color, and that's because of this pigment chromophene in these cells or in these tissues. Ganglioneuroma behaves like paraganglioma biochemically. Neuroblastoma, it is a common malignancy in children. Can be adrenal or of sympathetic chain. Catecholamines humoral effect usually minor, so release of the hormone is usually less. The rapid growth and widespread metastasis is most common. Some differentiate and spontaneously regress. Treatment is complex, which consists of surgery, radiotherapy, and chemotherapy. Then we have chordectoma, which is because of the carotid bodies, they behave like paraganglioma biochemically. Glomer's jugular tumor, which is at the intracranial branch of the cranial nerve 9 and 10, behaves like paraganglioma. So how are these catecholamines? This is a complex pathway, but we need to know about them because different type of tumors, different type of pheos produces different type of hormones. So you get a combination of these hormones. One measurement can help you differentiate what kind of tumor and what genetic defect is there, which is causing this kind of which variety of the pheo is there. So what happens is the tyrosine, by means of tyrosine hydroxylase, is converted to the L-dopa, which is converted to dopamine. This dopamine by monoamine oxidase and COMT is converted into homovinilic acid. This is dopamine. So dopamine is converted into homovinilic acid. That's the metabolite of dopamine. Then this dopamine is converted into norepi, which is metabolized by COMT to normetanephrine. Okay? And this norepi is converted to epinephrine by this enzyme PNMT. This is very important enzyme. this epinephrine again by COMT is converted to metanephrine. So norepi's metabolite is normetanephrine and epi's metabolite is metanephrine, and both of these are then converted to vinyl mandelic acid or VMA, which is commonly known. So what happens is, if it is a large size tumor, a large pheo, then you will get the levels of these will be very high because of the excessive metabolism taking place. Small pheo, then the chances are these these are being released more. ठीक है, स्पोरेडिक है तो नॉर एपी ज़्यादा होगा, एपी कम होगा. फेमिलियल है तो एपी ज़्यादा होगा, नॉर एपी कम होगा. पैरागैंग्लियोमा है तो नॉर एपी ज़्यादा होगा. The reason for having more norepi in paraganglioma rather in pheo, which is from the tumor of the adrenal gland, is that this enzyme, the PNMT enzyme, is only present in adrenal glands. It's not present in the parasympathetic chains or sympathetic chains, so it's not present there. So because of that, and this enzyme is not there, so norepi is not converted to epinephrine, and that's why in paragangliomas you get norepinephrine. So if you're considering because of the symptoms, you're saying that patient might have pheochromocytoma, and you get the blood test done, and you see a rise in norepi levels, exclusively norepi levels on a higher side, then the chances are that this patient doesn't have pheo, has paraganglioma. Then again, caudectoma and glomus jugular causes norepi, ganglioneurioma causes norepi. The malignant pheo. So more the malignant the tumor is, the more dopamine and its metabolite is released, because these enzymes are not functional there. Achha, even in case of the large pheos or large adrenal tumors, what happens because of the tumor having its own blood supply, they lose this enzyme, the PNMT enzyme, and a very large tumor can also be, adrenal tumor can also cause excessive release of the norepinephrine. So where are these hormones acting? They are acting on adrenergic receptors. So we have how many types? Alpha adrenergic receptors and beta adrenergic receptors. What does alpha again further has alpha 1 and alpha 2. Alpha 1 is responsible for vasoconstriction, intestinal relaxation, uterine contraction, pupillary dilatation, while alpha 2 is presynaptic norepinephrine, on which the clonidine acts. This is and helps in platelet aggregation, also causes vasoconstrictions and decreases the insulin resistance. So the beta adrenergic, on the other hand, are beta 1, beta 2, beta 3. Beta 1 increases the heart rate, it causes increased contractility, lipolysis, increased renin secretion. Beta 2 in turn is responsible for vasodilation, bronchodilation, and increased glycogenolysis, while beta 3 is responsible for increased lipolysis and increased brown fat thermogenesis. So just imagine if these hormones are increased, what will happen to the body. So those are the symptoms which these patients will have. So epidemiology, 0.01 to 0.1% of hypertensive population. So hypertension, whenever you see a patient who is hypertensive and is a young patient, and then it is more male, is predominantly it's common in male, and is in 3rd to 5th decade of life, and has severe symptoms and severe hypertension, has gone through hypertensive crisis, it has a refractory hypertension, that is taking more than 3 drugs, and it is usually present, and if this hypertension was present at the age less than 20 or more than 50, usually it is common between the age of 3rd to 5th decade of life, but still if there it is, then you have to think of pheochromocytoma. You have to rule out secondary hypertension. Pheochromocytoma is one of the causes of secondary hypertension. The most common is the cons, followed by the pheo. Actually, that's the hormones, while the most common non-hormonal cause of the secondary hypertension is renal artery stenosis. So even in cases of hormones, when you're thinking of hormones, you have to think of pheochromocytoma. So we work them up. Patients who have hypertension of younger age group, of this age group, and having severe hypertension. So first of all, ruling out the heart and the cardiac causes like coarctation of aorta and stuff, and ruling out the renal artery stenosis or kidney disease, we then start working for hormones, and in hormones we specifically look for pheochromocytoma. Then again, what happens, it is clinically suspected, it is also suspected when, because of some other reason, patient was having abdominal pain for some time and went for an ultrasound, and there was a little lesion on adrenal, or there was some lesion on the adrenal, or appeared to be in liver on ultrasound, and then that's why they had gone for a CT abdomen or something, and you find out that there is a tumor in the adrenal gland. So whenever you see a tumor in the adrenal gland, a lesion in an adrenal gland, you have to rule out pheochromocytoma. You have to work the patient up for pheochromocytoma before you go in and touch that and do the biopsy. You have to biochemically rule out that the patient has pheochromocytoma, have it or not have it, because if you don't do that, then you will be putting patient in danger by doing a biopsy of that lesion or anything, where that tumor will release the hormones and patient can go into hypertensive crisis. So these are the points which have to be considered, and these should give you clinical suspicion that patient might be having pheochromocytoma. A very small amount, 0.01 to 0.1%, is a very small is very small percentage of the population, but you have to keep it in mind. It's a very important clinical suspicion which you should have. So signs and symptoms, there are 5 P's. Pressure, so hypertension, which has present in 90%. Pain, headache, pain, perspiration, that is the sweating, and palpitations. So this is present in 80 to 71 and 64, and pallor. And the 6th P which you need is to remember is paroxysm. So what happens is that these symptoms, they are present, not present all the time. They will be coming and going. It will be episodic, and that is why it is called the paroxysms. Attacks of these symptoms will occur. The classical triad is this 3: pain, perspiration, and palpitation. This is classical triad. So patient will say, बैठे बैठे सर में दर्द शुरू हो जाती है और पसीने आते हैं और दिल की धड़कन तेज हो जाती है. So आप उससे फिर पूछेंगे कि कभी आपने उसको ब्लड प्रेशर चेक कराया है, तो maybe he or she gotten her the blood pressure checked and will say yes, उसको blood pressure बढ़ा हुआ था. So this is a classical triad these patients had, and lack of all 3 virtually exclude diagnosis of pheo in a series of more than 21,000 patients. So it was completely ruled out in these patients. So spell जो paroxysm है वो कितनी देर का होता है? It can be from 10 minutes to 60 minutes. So 1 घंटे तक रह सकता है. And it can be daily or once in a month or twice in a month. You cannot say कि they cannot predict that this is going to happen. It can be spontaneous, or it can be precipitated by diagnostic procedures like by giving IV contrast or certain drugs like opioids, unopposed beta blockade, anesthesia induction, histamine, ACTH, glucagon, metoclopramide, anything which can cause the release of these hormones will in turn result in precipitation. Strenuous exercise, especially movement which increases intra-abdominal pressure. So any lifting or straining that can cause pressure on the adrenal glands. Micturition, the bladder paraganglioma, if there is a paraganglioma around the bladder, then during micturition this can happen. So sometimes there can be hypotension as well, and this is also paroxysmal. So hypotension, we should not forget this hypotension, which is this hypertension should not get fixed in our mind. We should think of spells of hypotension can also be a clue towards the pheo. So what happens is extracellular fluid volume is contraction takes place and loss of postural reflex due to prolonged catecholamine stimulation and tumor release of adrenomedullin vasodilatory. So when they cause the vasodilatory neuropeptides, they are released and that can cause orthostatic hypotension. Other signs can be no sign or symptom or abdominal pain or severe constipation because of megacolon. In chest pain, anxiety, or angina-like symptoms, because catecholamine can induce increased myocardial oxygen consumption or can cause coronary vasospasm. So it can present with chest pain. It can lead to heart failure, one because of the hypertension and hypertrophic cardiomyopathy leading to diastolic dysfunction, and second can be because of the catecholamines themselves causing dilated cardiomyopathy leading to systolic dysfunction. Then these, because of their stimulatory effect on the heart, they can cause dysrhythmias, cardiac dysrhythmias, and conduction defects. Hypercalcemia is actually associated with men. Multiple endocrine neoplasia type 2, in which these patients they can have hyperparathyroidism. So these patients have hypercalcemia. And then not only that, the pheochromocytoma, the tumor itself can cause release of parathyroid hormone related peptide. So when PTH related peptide is released, then this can also cause the hypercalcemia in these patients. It also causes mild glucose intolerance and the lipolysis, resulting in ketosis because of the increased VLDL synthesis. A very important rule to remember, rule of 10, easy. 10% are extra-adrenal, so 10% won't be in the adrenal gland, will be outside the adrenal gland. 10% occurs in children, 10% in families, 10% bilateral on both the kidneys. So if it is in one side of the adrenal gland, it will be on the other side of the adrenal gland. 10% recur. So if you take them out, it doesn't mean you have cured them. There is 10% chance that they will be recurrence. 10% of them might be malignant. We call them malignant when they spread, when they have metastatic disease. 10% are discovered incidentally just because of an abdominal pain. Patient got his CT scan, or because of some other reasons the CT scan was done and you find out a tumor in his adrenal gland. Familial pheo, you have to know about this. Whenever you are thinking of pheo or whenever a patient is diagnosed as pheo, you have to look for the familial causes. You have to see for the other features which might be present there, which might point toward syndromes. So MEN2A, multiple endocrine neoplasia type 2A, 50% have pheo, along with that medullary thyroid CA and hyperparathyroidism. So MEN2A or MEN2B, in which pheo with medullary thyroid carcinoma along with mucosal neuromas or marfanoid habitus. What's MEN1? MEN1 has 3 P's: pituitary, parathyroid and pancreas. सही है? MEN2 has pheo and medullary thyroid carcinoma. 2A में हाइपर पैराथायराइड आ जाता है और 2B में हाइपर पैराथायराइड की जगह म्यूकोजल न्यूरोमा और मार्फनाइड हैबिटस आ जाता है. Then we have von Hippel-Lando. Von Hippel-Lando has 50% pheos which are bilateral, and then there is retinoblastoma, hemangioma, nephroma. So they have tumors everywhere in the body, and you have to remember that. Then neurofibromatosis type 1, von Richardson syndrome. So this is 2% of pheos, 50% if NF1 and hypertension is present, then there is 50% chance that these patients have pheo as well. So what is the classical feature of NF1 is cafe au lait spots and neurofibromas and optic gliomas. Then there is familial paragangliomas, familial pheos and islet cell tumors. Others can be tuberous sclerosis, Sturge-Weber disease, ataxic telangiectasia, Scarnese triad, pheochromocytomas, and pulmonary chondromas. They can all be they all are these are the conditions which are associated with pheo. So when these are diagnosed, then pheo has to be looked for, and when pheo is diagnosed, then these conditions have to be looked for. So how you diagnose these patients? There are two things to do. First of all, you have to confirm the diagnosis by doing biochemical testing, and then when biochemically you have confirmed that patient is releasing high hormone levels, then you have to localize that where this tumor is. So what you do a 24-hour urinary collection, and in 24-hour urinary collection, what you do is creatinine, catecholamine, methamphetamine, vinyl mandelic acid with or without dopamine, thinking whether the metastatic disease is there or not. Positive results 2 to 3 means if the levels are more than 2 to 3 folds. If it is more than 2 folds, then upper limit for the total catecholamines or urinary catecholamines if it is more than 2 folds, or urinary total metanephrines if they are more than 1.2 microgram per dl, and urinary VMA more than 3 folds elevation. So if you're doing the catechols, you have to look at the level should be 2-fold the upper limit, and VMA if you're doing, then it should be 3-fold elevations. Initially in Pakistan, we used to do VMAs because these were not available. Now, as these are available, we're not doing these VMA because VMA assays are not that sensitive and specific. The catecholamines, the urinary catecholamines, and total metanephrine levels, these are more specific. Their specificity is around 90 to 99%. So, again coming back to this one, so urinary catecholamines 83 to 88% specific, while metanephrines are 94% specific. And when you do both of them, then the sensitivity and specificity is more than 90 to 98%. So they can guide you more properly. VMA are not sensitive. 63% is sensitivity, and specificity. So this is not considered as gold standard anymore. Sensitivity increases if this is done at the time of the paroxysm. So if the symptoms have started occurring and you do the test, then the sensitivity increases. 24-hour urinary can be false positive if patient is taking all these kinds of drugs like tricyclics, antidepressants, levodopa, methyldopa, labetalol, propranolol, clonidine, illicit drugs like opiates, amphetamine, cocaine, ethanol, some pathomimetics for cold remedies. So even if it is positive, it is not you cannot be sure of it. So what you have to do is, if patient is on these drugs, you have to hold these medications for at least 2 weeks. Major physical stresses like hypoglycemia, stroke, raised ICP can also cause false positive 24-hour urinary test. And then obstructive sleep apnea can also lead to the 24-hour urine false positive test. Then we come to the plasma catecholamines, drawn with patient fasting in supine with an indwelling catheter in place for more than 30 minutes. So basically you want the patient to be relaxed before you get the sample, because when you're stressed, what is released? Catecholamine is released. So plasma total catecholamines, if more than 11.8 nanomoles or 2000 picogram per ml, sensitivity is 85 to 80%. False positive can occur just like that for the 24-hour urinary test, as well as if the patient is diuretic and is smoker. In cases of CRF and end-stage renal disease, where patients are oliguric to anuric, that is, they're not producing enough urine, so you cannot do a 24-hour urine test, it will become inaccurate. Plasma epinephrine, best test for pheo in end-stage renal disease. Plasma norepi and metanephrine's falsely elevated in end-stage renal disease. So what you need to do in the end-stage renal disease, you need to ask for epinephrine rather than for norepi and metanephrine. Plasma metanephrine are not postural dependent and can be drawn normally, and they are secreted continuously by pheochromocytoma because these are the metabolites. Sensitivity is 99 to 89%. False positive is acetaminophen is done. It is not available in Canada, but it is available in Pakistan. So sensitivity and specificity, biochemical testing, urinary catechols, 83% sensitive, 88% specific, urinary total metanephrines, 76% sensitive and 94% specific, urinary catechols and metanephrines 98% specific, while plasma metanephrines are 99% specific. So sensitive. So these two tests in combination can be done. But what we would usually do is plasma metanephrine because sometimes these are missed. So because of this less sensitivity, they are missed. So plasma metanephrines are usually our best choice. Then we can do certain suppression or stimulation tests, the provocation tests, like all we do in all the pituitary hormone evaluation or any hormonal evaluation. So you do. There are two things: clonidine suppression test and glucagon stimulation test. But these are no more being done. One, because of the good quality of the urinary assays and the serum assays, as well as because of their side effects. Clonidine, unlike in normal people, doesn't cause anything to the normal people, but in patients with in normal people, what happens in normal people, that when you give clonidine, there is suppression of the release of the catecholamines, the norepi. But in cases of pheo patients, it won't suppress their plasma norepi. Okay? So if the patient is normal, he can go into hypertensive shock. Glucagon may precipitate hypertensive crisis. What happens is that normal people, when they are given glucagon, there is no rise in plasma nor epinephrines, and the blood pressures are not affected. But in pheo patients, when this is given, it causes a 3 times increase in the norepinephrine, and they go into hypertensive crisis. So clonidine doesn't do anything to the pheo patients, and the levels are not affected in pheo patients. But in normal people, it causes suppression of the catecholamines. Okay? Glucagon causes nothing to the normal patients, doesn't lead to hypertensive crisis in normal people. But if patient has pheo, patient will start having hypertensive crisis, might go into hypertensive crisis because the plasma norepi levels will be more than 3 times. So their effect is opposite, not only opposite, but the patient type of the person affected is also opposite. So now when you confirm by the biochemical profile, you go towards the localization, and localization is basically done by imaging. Imaging is CT abdomen and by MRI. So MRI is more sensitive than CT for extra-adrenal pheos. So when you're looking for adrenal pheos, then the sensitivity of CT abdomen is 93 to 100%. But if you're looking for extra-adrenal, then better to do an MRI. So this is the MRI. Adrenal pheo can be seen. You can see this is adrenal. Sorry, this is the spine, and the white arrow demonstrates the displaced inferior vena cava, while the black arrow, basically this is the inferior vena cava, which is being displaced, and this white arrow is directing towards the tumor. And here it is clearly seen, the large big pheo can be seen. So and then beside MRI we have MIBG scan, okay, which is sensitive to 77 to 90% and specificity is 95 to 100%. What is MIBG? It is iodine 123 or 131 labeled meta-iodobenzyl guanidine. So MIBG, it's a catecholamine precursor which is taken up by the tumor. We inject MIBG scan at 24 hours, 48 hours and 72 hours. Lugol's 1 GTT is given 3 times a day for 9 days from second day prior until 7th day after MIBG injection to protect the thyroid gland. So you आप ये देंगे 9 दिन के लिए पहले, ठीक है, 2 दिन पहले से और 7 दिन, ताकि ये जो है जाके थायराइड में बैठ जाए, और थायराइड ग्लूकोज इज आयोडीन ना, सो वो जाके थायराइड में बैठ जाए, थायराइड उसको ले ले और थायराइड फुल हो जाए उससे। सो जब आप MIBG लेबल्ड आप आयोडीन दें तो वो थायराइड के अंदर ना जाए और थायराइड को डिस्ट्रॉय ना करे। सो यू हैव टू गिव ग्लूकोज बिफोर गिविंग MIBG। फॉल्स नेगेटिव, अगेन इसमें भी फॉल्स नेगेटिव और पॉजिटिव हो सकते हैं। फॉल्स नेगेटिव स्कैन इन occurs when the drugs are like labetalol, reserpine, TCAs and phenothiazines are being taken. So these have to be hold for 4 to 6 weeks prior to the scan. ठीक है? And this is a metastatic disease. So you can see the mets here. These are the metastases which are visible. देखो liver में भी नजर आ रहा है. So this is the MIBG scan, how it looks like. Beside MIBG, you can do indium pancreatide scan, that is a some pheos have somatostatin receptors. Then there is PET scan, which is used fluorodeoxyglucose and fluorodopamine. जो dopa PET है या dopamine वाला है, that is a much better option. And now there is another technology, DotaTech, which is kind of a PET scan that require using dopa, and it is being used. So what do you do if you are considering that there is clinical suspicion of the patient to have pheo? You discontinue the interfering medications, and then high suspicion is there, then you do 24-hour urinary, total metanephrine, catecholamines and plasma metanephrines. If normal, then recheck with a spell. If normal, then you investigate other causes of spell. If it is twofold elevated in catecholamines, or it was normal initially and you rechecked during spell and it was twofold elevated, ठीक है? Or you had a low suspicion. So if you had a low suspicion, you just do metanephrine, urinary metanephrine levels, and you look at the elevated, whether it is elevated or not. When they are elevated, then you localize by doing adrenal or abdominal MRI or CT scan. And then you look for adrenal or para-aortic mass. If it is adrenal or para-aortic mass, you do an MIBG scan, and then if it is positive, you proceed for MIBG is basically being done for metastatic disease. So you do that, and then you proceed for preoperative alpha adrenergic blockade, and then you go for surgical resection. You did an imaging scan, it was CT scan, it was negative. So what will you do next? You will consider either the MIBG, pancreatide, or whole body MRI, PET scan, whatever is available at your setting, and then you will look for the tumor. So you look at the whole body for it, and if you find a tumor, then you go for the preoperative alpha and beta blockade, and then go for the surgery. So now comes the management. We have preoperative, operative, postoperative. So what is the management of these patients? They have to go through the surgical resection. The tumor has to be removed. So ऑपरेशन से पहले, ऑपरेशन के दौरान और ऑपरेशन के बाद. The main problem with these patients is their hypertension. You need to control the hypertension. Another problem is as soon as the abdomen is open and the tumor is touched, there is release of these catecholamines are released, and so patient can go into hypertensive crisis. So you have to prepare the patient in such a way that patient doesn't go into hypertensive crisis during surgery. Or there's another thing, that the moment you clamp the vessel, the adrenal gland vessel, before removing it, what happens, all the catecholamines which were being released into the blood, they get blocked, and when they get blocked, then there is chances of having severe hypertension. So you have to correct and prepare patient before going on for surgery. So prior to 1951, reported mortality for excision for pheochromocytoma was 24 to 50%. And the reason was hypertensive crisis, arrhythmia, MI, stroke, or hypotensive shocks. Currently, mortality is only 0 to 2.7%. Preoperative preparation and alpha blockade helps, and now new anesthetic techniques like anesthetic agents, intraoperative monitoring lines, EKG, CVP, swan gowns, they all have helped, and that is the reason that the mortality has come down. The main thing which is very important for the management is that there should be experienced and coordinated team, an endocrinologist with anesthesiologists and surgeon who have worked a lot in this field and know about these patients should be involved in the treatment of these patients. So what should be the pre-op workup? CBC, the complete blood culture, electrolytes, creatinine, INR, PTA, APTT, chest X-ray, EKG, echo to rule out the dilated cardiomyopathy secondary to catecholamines. Then what you do is that you combine alpha and beta blockage. You give phenoxybenzamine, selective alpha-1 blocker like prazosin and propranolol. You try to bring the blood pressure within the range and the heart rate within the range. You have to give alpha blockers first for some time, for like 3 days to 1 week, and then you put the patient on propranolol. Other drugs which can be given are metazocine, nicardipine. No randomized clinical trials have been done to compare various regimes, and the reason is that the number of patients is not that high. So how you do it, you to start at least 10 to 14 days pre-op. So before that, 2 weeks at least before, you have to start the treatment, and you to allow sufficient time for extracellular volume re-expansion. So when you give these fluids, these things, these drugs, then ECF might shrink. So let it come back to its normal, expand to its normal quantity. So you have to give it for 10 to 14 days before the surgery. Phenoxybenzamine is special pharmacy assessed. It is not easily, phenoxybenzamine is not available in Pakistan. It is drug of choice. It's covalently bind to alpha receptors, and it has more affinity for alpha 1 than alpha 2. We start with 10 milligram orally BID and increase the dose by 10 to 20 milligram and increase until baby is controlled and there are no more paroxysms. Maintain it at 40 to 80 milligram per day. Salt load of sodium chloride 600 milligram TID as tolerated to prevent extracellular fluid shrinkage in these patients. If the side effect is orthostasis with dosage required to normalize seated blood pressure and reflex tachycardia, and drawback is peri-op hypotension and shock unlikely to respond to pressor agents. So अगर हाइपोटेंशन हो गई तो आप ये जो प्रेशर डोपामीन लेवोडोपा ये हम देते हैं, ये चीज़ें हेल्प नहीं करेंगी इस पेशेंट को क्योंकि वो ब्लॉक कर दिए हैं ना रिसेप्टर्स. Then we have selective alpha blockers, prazosin, trazasocine, doxazocine. So usually the prazosin is the one which is being used. Not routinely used as incomplete alpha blockade, but in Pakistan these are the ones which are available, so we are using this. Phenoxybenzamine is not available here. Has less orthostasis and reflex tachycardia than phenoxybenzamine. Used more for long-term treatment, inoperable, usually used for inoperable, but we are using them for pre-op preparation as well, as phenoxybenzamine is not available. So when you give these alpha blockades, there is reflex tachycardia. So used to control the reflex tachycardia, you give beta blockers and prophylaxis against arrhythmias. Start only after effective alpha blockage because it can precipitate hypertension. Is suspected heart failure or dilated cardiomyopathy, then low dose से शुरू करें. Propanol, most studied in pheoprep, is started 10 milligram BID and is increased to control the heart rate, and it can be given as much as required. If patient PP is still not controlled despite alpha and beta blockers, then prazosin to, अगर phenoxybenzamine दे रहे हैं तो prazosin ऐड कर दें, calcium channel blockers या ACE inhibitors ऐड कर दें, but do not give the diuretics because it will cause diuresis, which will lead to dehydration or loss of extracellular fluid which is already contracted, and metazocine can be given to these patients. So when the day you're going for the surgery, you give the drugs are given. So you're giving the drugs 2 weeks before, you have managed the patient, you have stabilized the blood pressures, you have stabilized the heart rate, and now the patient is going for the surgery. So when he goes for the surgery in the morning, you give the morning dose to these patients. During operation, what you do is you give IV phentolamine, which is a non-selective alpha blocker. Test dose is given 1 milligram, then 2 to 5 milligram IV, 1 to 2 hourly, or as continuous infusion. So as required या continuous infusion titrate करते हैं BP के लिए, or IV nitroprusside, which is a calcium channel blocker. So these are the drugs which are given to control the hypertensive crisis occurring during the surgery. Peri-op arrhythmias have to be controlled by IV esmolol and hypotension. So there is chances that patient might go into hypotension, and it usually occurs the moment the artery is clamped by the surgeon. So what you give is IV crystalloids plus minus colloids. And you can also do auto transfusion. That is, you take the patient's blood, save it, and during the surgery you transfuse the patient's same blood. So during hypertensive crisis, you can give phentolamine, nitroprusside, IV esmolol, and IV labetalol, combined alpha and beta blocker, which is a combined alpha beta blocker. Metyrosine can also be given, which is a synthetic inhibitor of tyrosine hydrolase. So this tyrosine hydrolase is the enzyme converting tyrosine to levodopa. So you give metyrosine, this is blocked. So when this is blocked, nothing will be formed. Special pharmacy SS, this is not available. (250 milligram QID, maximum 1 gram QID is the given. That is once daily. Severe side effects like sedation, extrapyramidal effect, diarrhea, nausea, vomiting, anxiety, renal colic, stones, galactorrhea can take place. Alone may insufficiently control blood pressure, and reported hypertensive crisis during pheo operation has been observed. Restrict use to inoperable or malignant pheos or as adjunct to alpha and beta blocker or other pre-op prep. So अकेले नहीं देना है इसको, ठीक है? Calcium channel blockers, only 6 cardiovascular the experience by Cleveland Clinic is that only 6 cardiovascular complications all occurred in patients who had pre-op alpha blockade given. 30% received no medication pre-op if no hypertension. Patients not receiving phenoxybenzamine requires less fluids. Okay, sorry, this is the complications for metyrosine. So calcium channel blockers, they block norepinephrine mediated calcium transport into vascular smooth muscles. So if you have nothing available, you can give a calcium channel blocker. Nicardipine is the most commonly used calcium channel blocker. So what is nicardipine? It was done in France to see the effect of the nicardipine, and 24 hours it was started 24 hours to few weeks pre-op to control blood pressure and allow the extracellular fluid restoration, and after intubation IV cardipine was given to these patients. IV nicardipine then adjusted to according to systolic blood pressure. It was stopped prior to ligation of the tumor venous drainage, and then it can cause tachycardia, which was treated with IV esmolol. Advantage is peri-op hypertension may still respond to pressor agents as opposed to those patients who are completely alpha blocked. So अगर आपने alpha blockage दे दी तो फिर आप pressor agents like dopamine and you cannot levodopa and these cannot be given to these patients because वो जो जहाँ पे जाके डोपामीन ने इफेक्ट करना है आप उसको ही रिसेप्टर को ही ब्लॉक कर देते हैं, so it won't be effective. So आपने जब calcium channel blockers दिए, then those receptors are still available. So if patient is going into hypotensive shock after clamping the tumor, that is the point. Then with the calcium channel blocker, the good thing will be that these pressors, the dopamine and other pressors given at the time of the shock will be helpful. Cleveland Clinic में देखा गया था that only 10% received phenoxybenzamine. Calcium channel blocker was first line agent as pre-op per oral medication. Selective alpha-1 blockers, prazosin, terazosin, and daxazosin was added to calcium channel blocker if BP was still high. And peri-op arrhythmia, For that, IV esmolol was given, and peri-op hypertension was treated by IV nitroprusside. Peri-op hypotension was treated with IV crystalloids or colloids, and as the calcium renin blocker were given first line into these patients, therefore dopamine, norepi, epi, and phenylephrine helped these patients when they had peri-op hypotension. So, before going to the operation theatre, you admit the patient night before for overnight IV saline. You give maintain arterial line. You do EKG monitoring, the CVP line. You look at the CHF by doing Swan Ganz or CVP line, and you measure the CVP pressure. Regardless of pre-op medications, you have to have the IV phentolamine, nitroprusside, and esmolol with you, and to treat hypotension, the crystalloids and colloids with you. And a CVP12 or VEG15 has to be done. Inotropes, you have to keep the CVP after passing the CVP pressure. The central venous pressure has to be maintained at 12, or the wedge pressure should be 15. Inotropes may not work, so keep this in mind because of the drugs. The inotropes, which is the same hormones which you are treating the patient for, because of which you are treating, they may not be working or may not work here. Anesthesia, enflurane or isoflurane don't sensitize myocardium to catecholamine, so this can be given, and halothane should not be given because it sensitizes the heart and causes arrhythmia. Laparoscopic adrenalectomy should be done if tumor is less than 8 cm. If tumor is more than 8 cm, then open surgery needs to be done. Most cases can stop all BP meds post-op. So post-op, most of the patients, they come off the medications. Post-op hypotension is a possibility, so IV crystalloids has to be given. Hypertensive free time period is 5 years. Was seen for 5 years, 74% remain hypertension free for 5 years, and 45% stay hypertension free for 10 years. Then after 2 weeks of the surgery, do a 24-hour urine collection. Surveillance is to do 24-hour urine collection once per year for at least 10 years, and follow-up is lifelong. If it is unresectable or it is malignant, having metastatic spread, so how are you going to treat? You give alpha blockades, either selective alpha 1 or phenoxybenzamine, which has a complete alpha blockade, so you can give them, and then along with a beta blocker, calcium channel blockers, and ACE inhibitors to control the hypertension. Nuclear medicine, the high dose MIBG or octreotide, depending on the MIBG or octreos can pick up, you can give them, which will burn the tumor, sensitize the tumor, or you can also give the chemotherapy. These medications can also make tumors responsive to carboplatin and 5-FU chemotherapy, which is the chemotherapy given to FeO patients. Okay, what happens if in pregnancy this is happening? 24-hour urinary collection and MRI needs to be done. You cannot do the CT scan because if the patient is pregnant because of the radiations. No stimulation test, no MIBG if present. In first and second trimester, less than 24 weeks, phenoxybenzamine plus beta blockers. Resect the tumor as soon as possible, laparoscopy. In third trimester, give phenoxybenzamine and beta blockers, and if fetus is large enough, then cesarean section, and at the same time you can resect the tumor. That's all about the pheochromocytoma. I hope you guys understand it.